Good morning, everyone. Welcome to Grand Rounds. It's really my distinct pleasure to welcome Chris Conrady back to the Moran Eye Center. He is really a part of the Moran family, having spent 5 years here during his residency and fellowship. For those of you who don't know Chris, he received his undergrad at Oklahoma University, his MD, PhD from Oklahoma, and he did his residency from 2014 to 2018 at the Moran Eye Center, where he was a superstar, and a uveitis fellowship between 2018 and 19. Again, motivating us all to look hard at patients and come up with ideas and publish them, actually. He did his vitreoretinal fellowship in Michigan and was recruited to the University of Nebraska Medical Center and has been there since September 21st, where he serves as the Joseph J. Humps Endowed Professor of Ophthalmology, Assistant Professor of Ophthalmology, Immunology, Pathology, and Microbiology. His research interests include innate immunity related to viral infections of the retina, and his clinical research interests include multimodal image findings in inflammatory diseases of the eye and the early identification and treatment of endophthalmitis. He has 61 publications as first, senior, or co-author in at least 6 book chapters, which has received many honors and awards and presentations nationally and internationally. Chris is truly a triple threat and a true clinician scientist. Actually, I should say he's a quadruple threat because he's also a father and a husband to a lovely family, Catherine, who's a nurse practitioner, and 2 beautiful children, Cooper and Caroline. It is, I think, Chris's hope to parlay and leverage his multifaceted interests in basic science and translational research and his clinical expertise in vitreoretinal surgery and in uveitis into discovering how the innate immune system mediates disease in both infectious and non-infectious diseases of the retina, and to understand the pathogenesis and come up with treatment modalities that make sense. He is truly a gentleman and a scholar, and an absolute pleasure to work with. I have to say that I haven't met too many people with so much enthusiasm for learning and scientific inquiry, and just fun to be around. He is infectious, and enthusiasm is infectious to be around. So I'm really looking forward to his talk, A Common Virus and Irreversible Blindness. Can innate immunity cure this disease? Chris?
Dr. Patil, thank you for those kind comments. I really appreciate those. I'll pay you later for those effusive kind of comments there. So I'm going to talk about some work that I've been interested in for a long, long time. And now I have grant funding to actually pursue some of those interests. And I know that I'm talking to a room of mostly clinician scientists. And so I've tailored this talk, at least this morning's talk, to a more clinical realm and clinical questions spinning out of my hopefully translational research lab. If you want to know more science, come back at 12 and I'll be talking deeper kind of science. So a couple of quick disclosures. I have funding from a couple of different places. And then I also have a provisional patent on some work that I will be presenting. And I'll talk about that as we go. So let me give you a brief overview of what I'll be talking about. So I'll give you some background, the disease we're all familiar with, acute retinal necrosis. I'll give you a very brief synopsis on innate immunity. I won't dive too much into that because I know it's early. It takes a lot of caffeinated products and maybe later in the day to discuss deep topics like that. And then I'm going to attempt to answer some questions, or at least partially answer some questions that may have baffled the ophthalmology community in regards to acute retinal necrosis, or maybe just me. Maybe it's just me thinking about this, but that's okay. And then we'll go through some conclusions of what I showed today. So acute retinal necrosis is a viral infection of the retina, pretty damaging, with most patients ending up in legal blindness. It's due to a group of herpes viruses that are DNA viruses that are most of us are seropositive for, so 90% of the adult population is seropositive for HSV1. So they've been exposed to the virus at some point, and then presumably reactivates in the retina, but can also presumably be a primary infection. It is an aggressive disease with blindness developing in hours to days. And even with the most aggressive treatment, is still has pretty poor, abysmal outcomes. There is a well-known association with concurrent encephalitis. So not only talking about a blinding condition, but maybe a lethal condition. And so something to consider as ophthalmologists as we're taking care of these patients. There's not a lot known on this disease, actually. And in fact, what we do know from human samples is that there's broad upregulation of a whole bunch of pro-inflammatory cytokines, but otherwise really no mechanistic kind of thought in acute retinal necrosis. If we kind of step back and look at viral susceptibility to infections and look at herpetic encephalitis, where we have much more information and a better understanding, there is a group of children, and there's actually been some adults as well that have been shown to have pathway or toll-like receptor 3 pathway deficiencies that make them more susceptible to developing herpetic encephalitis and actually developing recurrent herpetic encephalitis. So really big deal when it comes to the innate immune response. And again, I'm just briefly alluding to that, and I'll kind of walk you through that as we go. So the three important clinical questions I want to kind of pose today are the following. Why do some patients develop ARN, but most others do not? Can we utilize host innate immunity to identify therapeutic targets or drugs? And then lastly, why does ARN typically start in the periphery? So let's first start with this first question. So first, I need to give you a little bit of background on innate immunity. Again, I said I would be very brief. So think of innate immunity as the watchtowers on a castle. We have different watchtowers. They recognize different invading pathogens. They then activate pathways to then what we'll be focusing on today, antiviral proteins known as type 1 interferons, at least in the case of viruses. Okay, there's a whole bunch of different innate immune sensors. We'll be kind of focusing on the toll-like receptors, which I'm sure all of you have heard of, may not know much about. So I don't really need to belabor this point, but why the eye? The eye responds immunologically, we think, in a very different way than most other tissues. We think this is related to immunological privilege as well as immune deviation. But again, I'm not going to get too much into this except to recognize the fact that we find something in another tissue that may not necessarily portend or play out within the eye. So I had already kind of told you that kids are prone to developing recurrent herpetic encephalitis that have toll-like receptor 3 pathway deficiencies. Again, that's one of these innate immune sensors, one of these watchtowers. And so my lab was kind of founded on the premise of the retina and the brain are similarly derived from embryological origins. And so we hypothesized that a loss of toll-like receptor 3 would result in the loss of interferon production, so that antiviral protein, and then that would lead to a loss of viral control within the retina. So again, this is kind of untested territory, at least when it comes to the retina. We have looked at innate immunity in other capacities, but not necessarily in infectious diseases. So first, I created a mouse model when I first started at Nebraska, in which we inject HSV1 into the subretinal space of a mouse, creating basically a bleb just like we would do with gene therapy. Mouse develops acute retinal necrosis, so retinal whitening. You can isolate virus, as you can see here in the right-hand picture. This is 5 days post-infection. So then we said, okay, let's use our mouse model of acute retinal necrosis that seems to at least exhibit a lot of features of the clinical disease that we see, and ask the question, can we identify the antiviral response to HSV1 in the retina? And so if we knock out kind of broader proteins, so these are downstream adapter proteins, so just kind of take this first figure and say, okay, we're looking at all the toll-like receptors. There's 13 of them within this figure. We show in this top figure that if you knock out toll-like receptor 3, so TRIF in this case, that you have an increased amount of virus you recover from the retina. If you knock out the ability to respond to type 1 interferons, you also lose your ability to contain the virus within the retina of a mouse, okay? That also leads to worse pathological scores. So if we go through and look at histopathology or even in vivo OCT imaging of these mice, you can see TRIF mice there on the far right in the bottom figure, both in the anterior segment OCT or in the retinal OCT, have a lot more inflammation. There's diffuse kind of necrosis, or what we presume is necrosis of the tissue, and then that plays out also in the H&E pictures there. And then we went and quantified it in that top right picture. So not only do we lose viral control, but we also have worse tissue pathology, suggesting that this is a visually significant process. So the next question, and it's kind of a debate within the innate immune world and the retina world, are toll-like receptors expressed in the retina, and do they respond as they do everywhere else? Well, TLR3 is broadly expressed in the mouse retina. And then if we knock out toll-like receptor 3 here on the right, and then this bottom left-hand panel, we see that compared to wild-type controls, you lose not interferon beta like we had hypothesized, but actually interferon alpha production, okay? And we subsequently identified the subspecies of interferon. So there's 13 different interferon alpha subtypes. Seems to be interferon alpha 4 in mice. I'm not going to talk too much about that, but we have actually identified the actual subspecies of interferon. So then the question became, and my goal, long-term goal from starting the lab was, can I affect human disease? And so can I take something from a mouse model and translate that to human disease? And so I said, well, how am I going to test that? I can't go in and just inject a whole bunch of patients with, siRNA and knock down toll-like receptor 3 in the retina and see what happens, right? So I said, okay, let's think creatively. And so I said, okay, let's reach out to the Lions Eye Bank, the eyes that they're not using. Let's see if they'll give me the globe that they can't use for corneal transplants. Let's take some punch biopsies of those retinas, see if we can keep them alive in tissue culture, which we can, and then infect them ex vivo. Okay, so it's not the real disease, but we're at least infecting the tissue. We can show that we can infect the tissue. We see that histopathological changes, at least acutely, resemble those that we have from known clinical specimens. And then, does this tissue actually express toll-like receptor 3? Well, both the macula and the periphery express toll-like receptor 3. Okay, so we seem to have at least the beginnings of being able to test this. So then we said, okay, let's knock down toll-like receptor 3 in this model of now human disease ex vivo. So we knock down toll-like receptor 3, and then sure enough, we get more recoverable virus, significant amounts. So then we said, okay, the ultimate question, going back to human disease, do patients with acute retinal necrosis actually have deficiencies in toll-like receptor 3 or its pathway? Okay, so we went in, and this is in collaboration with Sunil Srivastava at Cleveland Clinic. We sequenced their toll-like receptor 3 gene and also the chaperone protein UNC93B, and said, okay, do we see single nucleotide polymorphisms in these patients? Sure enough, we see toll-like receptor 3 single nucleotide polymorphisms on the left-hand side here in a bunch of these patients. But then we also see a couple of novel UNC93B single nucleotide polymorphisms that we have no idea, do those actually reduce the function of the pathway? At this point, we don't know. The toll-like receptor 3, the answer is yes, okay? So then the question becomes, okay, we know that they have at least some effect on the toll-like receptor 3 protein. What about some of the chaperone protein that's critical in regulating toll-like receptor 3 activity? So then we looked at our case series. You can see here that a lot of them express these single nucleotide polymorphisms or have these. And the worst kind of cases, so bilateral disease, younger patients with a concurrent or history of encephalitis, all have these single nucleotide polymorphisms that we're interested in. So then we said, okay, well, let's take the gold standard of testing allele deficiencies, at least in infectious disease, and see if these single nucleotide polymorphisms actually reduce pathway functionality. And so the way that you do that is you take a cell that doesn't express toll-like receptor 3, it doesn't express the chaperone protein, UNC93B, and we put a reporter in it. So when that pathway is activated, luciferase activity lights up. Okay, so then you put in the single nucleotide polymorphisms, you compare that to wild type controls, and you look for luciferase activity. Okay, so we can transfect, if you want the scientific word, transfect all these different proteins into a cell. And then if we look, sure enough, the two single nucleotide polymorphisms that we predicted off of in silico analysis actually reduce the pathway functionality. Okay, kind of cool. So then let's move on. And again, we'll talk more science later if you want to talk, or if we have questions, I can answer those at the end. So then secondly, can we utilize host innate immunity to identify therapeutic targets and drugs? Okay, so we've already kind of belabored that type 1 interferons are critical antiviral proteins. If you don't have them, patients without or with deficiencies in these pathways die from COVID. They have really, really bad responses to other viral infections. Mice that you infect that have deficiencies in these pathways also die. It's a really, really bad thing. Okay, so type 1 interferons are critical. So we went back to our human ex vivo tissue, affected the tissue after knocking down toll-like receptor 3, identified a different interferon alpha subtype. We can talk about why there's a difference between mouse and human later. I don't have time for that, but can show that you lose the production of that when you knock down toll-like receptor 3. We then looked at human vitreous, showed that interferon alpha 1 is acutely expressed and produced during acute retinal necrosis. It then is no longer produced once the disease starts to resolve. So then we said, okay, can we take that human ex vivo tissue, infect it, then treat it with recombinant interferon? And sure enough, you can. So 24 hours after you do the interferon treatment, you see significantly less virus. And then that's only expanded the difference the longer you go after that single treatment of recombinant interferon. Okay, so that would suggest, at least to me, that you could use recombinant interferon intravitreally to help with this disease. Again, I'm not trying to say go do that on your patients. Akbar, don't try it yet. Let me do some more stuff first. But maybe we have an additional therapeutic. And then lastly, and it's kind of an emerging aspect of my lab that I don't have a ton of data on, but it's also been a question that I think I first posed to Dr. Vitale a long, long time ago. Why does ARN start in the periphery? I've asked a bunch of people that, and I've gotten the deer in headlights. I have no idea. It must be related to how nerves come into the eye. Maybe it's, you know, I've gotten a whole list of responses. None of them really felt immunologically driven, and I felt like this was an immunologically driven story. So I said, okay, is there a difference, first of all, in the ability or in the susceptibility to the peripheral retina versus the macula when it comes to infecting with virus? So again, I went back to my Lions Eye Bank samples, took a sample from the periphery, took a sample from the macula, infected both, and the periphery is more susceptible to herpes virus infection. Okay, so that would suggest to me at this point, this is immunologically driven. Because I'm doing this all ex vivo. There are no infiltrating leukocytes. There's no other story. There's no nerves to this. This is at least part of the process. So then, you know, why? Well, I don't know yet. So then I then hypothesized, well, maybe it's the location of the local innate immune cells. The only real local innate immune cell in the retina, well, there's a family of them, I guess, are microglia or macrophage lineage, okay? So I said, maybe it's a spatial distribution of microglia within the retina. So I said, okay, let's go in, take samples from the peripheral retina, take samples from the macula, then count the amount of microglia by flow cytometry. And so again, we're cleaning this up. This is fairly early, but you already see the farther you move from the macula out to the periphery, the lower amounts of CD45 positive cells. So those are just immune cells, broad marker. If you then add in CD206, so a microglia marker, again, statistically significant reduction in the amount of cells the farther you go out into the peripheral retina, okay? So then that says, okay, well, maybe there's an association there. It doesn't really test the science. but there seems to be fewer immune cells in the peripheral retina. So then back to our, well, I guess, continued use of this human ex vivo model. We then took clodronate to deplete macrophages and microglia. Again, there's some variability in this. We're cleaning this up because of the low N values, but we see a reduction in the amount of CD45 positive cells. And then we see an increased susceptibility of the macula after you deplete microglia. It does deplete macrophages at this point. So we're trying to further delineate that at this point. Is this a microglia or subset macrophage population that's driving this protection within the macula? And so it seems to be, at least at this point, and again, fairly preliminary, that the macula contains a macrophage microglia cell type that's important in viral protection. So do we have a local immunosuppression, so to speak, of the peripheral retina? And that's why we get acute retinal necrosis beginning in the peripheral retina and then moving centrally. Again, that will play out over time, but that's at least kind of where we're going with this. So I think I'm relatively on time. So a couple of conclusions. The TRIV-TLR3 pathway is critical in viral containment of the retina in both the mouse and human. Exogenous recombinant interferon seems to reduce the amount of recovered virus from the tissue. I don't show much else beyond that, but we are starting to look at the toxicity of interferon. So hence, not injecting it in your patients yet, because it does induce cell apoptosis, or can, as one of its mechanisms of action. And then we're looking at, does this change the histopathological changes and ERGs in treated mice versus those are untreated with acute retinal necrosis? And then the question still kind of being posed, and we're kind of finalizing the manuscript of this, is ARN no longer a spontaneous disease where you're just unlucky to get it, and it's maybe a genetic predisposition? Again, not all the patients in our cohort of 25 have a mutation that we've identified. So maybe most of them are genetically predisposed, maybe not. That will play out as we broaden and include more patients in this kind of sequencing algorithm that we have. And then lastly, there seems to be a spatial distribution of local immune cells within the retina that may cause a relatively immunocompromised state, thereby inducing or leading to acute retinal necrosis starting in the peripheral retina. So again, if you want to hear the science behind a lot of this, there's a lot of science that goes behind this. I'm talking more about that at noon, but I'm happy to answer any questions at this point. And I've had a lot of help. I cannot reiterate that enough. Some very, very, very important figures in the development of all of this, and so I cannot thank them enough. And then, of course, funding. If you don't have money, you can't do much. And so I've been lucky to have a lot of funding to do all this work. So, questions?
Good morning, everyone. So I have the pleasure of introducing our next two speakers. First up, we have Ayesha Patil, one of our PGY3s. She's going to be presenting a talk titled, "Is It Safe for Me and My Baby?" And speaking of babies, I personally am super afraid of heights, and I just recently found out that she is as well. To overcome this, about 10 years ago, she tried to bungee jump off the Nile. And I can say that that was unsuccessful. Ayesha Patil.
Thanks, Nana, for the introduction. And Dr. Conrady, thanks for your talk. That was amazing and difficult to follow. But today for my Grand Rounds presentation, I wanted to take some time to explore a topic that I was less familiar with, and that is specifically what ophthalmic treatments look like for women who are pregnant or lactating. So this is a general roadmap for my talk. I'll just be talking briefly about ocular changes during pregnancy, what FDA guidelines look like for the most common medications we use and how those have changed over the years, and then a framework of discussing these medications in quick cases, and then key takeaways. So as far as the population, there are 170 million women in the US who in 2023, and within that 6 million pregnancies each year. It's estimated that about 80% of those women are taking at least one medication for some underlying medical condition. And furthermore, about 20 to 40% of those women have some kind of ophthalmic complaint in a couple studies that were done. Looking at the different changes that can happen with the eye during pregnancy, and this is mostly from hormonal changes, increased estrogen, progestin, relaxin, going from outside to in. For the eyelids specifically, we tend to see increased pigmentation, and that's from increased melanogenesis and melanocytosis. And that can lead to melasma, or what's colloquially referred to as the mask of pregnancy. So you can see those hyperpigmented spots along the cheekbones in that upper right picture. As far as the cornea, studies have shown that there's potentially a 3% increase in central corneal thickness, and this is possibly due to hormone changes as well. Studies have shown an increase in estrogen and progesterone receptors on the endothelium, and this may lead to more fluid retention there. There's also a decrease in tear production and an increased tear breakup time. So this population can have more dry eye symptoms compounded on the general dry eye that exists in Utah. This is definitely something to be aware of whenever taking care of these patients. As far as IOP, studies have also shown that there's on average a drop of 2 to 3 millimeters per mercury. And this is most likely from increased aqueous outflow or decreased systemic vascular resistance that then leads to decreased episcleral venous pressure. And for the lens, sometimes there's transient loss of accommodation or sometimes fluid retention in the lens as well. So before we dive into cases, I just wanted to provide a framework on what FDA guidelines look like, because I'll be referencing the two different frameworks they use for labeling medications. In general, there's very limited data for this population. Before 2015, the FDA was using categories at A, B, C, D, X, A being the best, most well-studied and safe for pregnant and lactating women, and X being almost like a black label. In 2015 and onwards, they changed this to pregnancy and lactation labeling rule, with drug products having more of a risk summary. So it's more of a gray area, but allows more interpretation for the clinician when prescribing medications. And then you can find all of this information on FDA.gov open labels and look at individual medications there. So diving a little bit more into the categories, I'm mostly going to be talking about categories B and C. So for reference, category B means that there was no harm in animal studies and there were no human studies done, or there was harm in animal studies plus no harm in human studies. And then category C is essentially that risk can't be ruled out. So there's harm in animal studies, but no human studies have been done, or there's no animal studies and no human studies. So diving into a few quick cases, I'm mostly going to be focusing on the treatment. The cases are just to provide a framework. For the first one, we have a 24-year-old pregnant woman with history of contact lens wear presenting with acute eye pain and redness. Looking at the photo, there's diffuse conjunctival injection on the cornea. There's a whitish infiltrate with a history of contact lens wear. This is most concerning for a bacterial corneal ulcer. And generally, we treat these with moxifloxacin as the mainstay of treatment, sometimes fortified Vanc and Tobra, depending on the size and location. So looking at this, is Moxi a safe option for this population? This is what it looked like when I went to go search it. So I looked at FDA online label repository. Then I went to proprietary name search. I typed in Vigamox. Apparently there are multiple companies that make Vigamox. So I picked Novartis, and it has this whole section, and I just went to 8.1 pregnancy and 8.2 lactation. And this is where I realized, studying for like step 1 and all those tests, and when they have you interpret all of these guidelines, this was somewhat helpful when I was looking at this. But essentially, the key takeaways for moxifloxacin, there are systemic levels of moxifloxacin are very low following ophthalmic administration. And animal studies do not show any harmful effect at clinically relevant doses. So when they did study this in animals, they did show a harmful effect, but it was 277 times the clinically relevant dose of what's happening in one single administration of moxifloxacin eye drops. So in general, it is listed as a Class C category from the old FDA categorization, but it seems that if it was used appropriately and talking with the patient about the risks, you probably could use this medication. And then in lactating moms, the guidelines say it's also generally acceptable to use it. Looking at other antibiotic therapy options, everything is graded as a B or C, and some of the more safe options, polymyxin B would be a safe option. This has good gram-negative coverage. Erythromycins has decent gram-positive coverage, and that's also a B rating. For other infectious keratitis, when we're looking at fungal keratitis, typically I've seen us use natamycin drops here, but that does have a grading of C for pregnant women. So maybe amphotericin B could be a better option. For antivirals, it's really great to know that acyclovir, valcyclovir, PO are safe for pregnant women too. And then for acanthamoeba, chlorhexidine is the only one that's been studied as an oral rinse, and that has a grade of B. So moving on to another case, 35-year-old pregnant hyperopic woman presenting with acute eye pain, redness, and blurry vision. Looking at these slit lamp photos, attention drawn to the right one, you can see that there's kind of narrow angle there, pupils mid-dilated, probably most concerning for an angle closure glaucoma. So looking at different glaucoma medications, these gradings were taken from the AAO preferred practice patterns. I think this was the only group that had gradings for this population. But beta blockers has a grade of C, but these are used more often because they just have more long-term experience. So it seems that providers tend to use that more often. It is a category C during first trimester with possible increased risk of intrauterine growth restriction and fetal cardiac arrhythmia later on in pregnancy. And it definitely should be avoided during lactation for possible risk of beta blockade in the infant. And then brimonidine is probably the safest medication to use. It just needs to be stopped prior to delivery because it can be found in breast milk, and it does cross the blood-brain barrier and can cause apnea and somnolence in infants. So definitely avoid it in lactating moms as well. Carbonic anhydrase inhibitors have a grade of C. Oral Diamox, I'll dive into this a little bit more on the next case. It has shown some teratogenic effects, and it's a little bit controversial, but can be used. And then prostaglandins have a grade of C for a theoretical risk of increasing uterine tone and leading to preterm labor. So historically, we've just avoided that one for pregnant women. And then Rho kinase inhibitors haven't really been studied yet. Case 3, we have a 35-year-old pregnant woman, positional headache, blurry vision, double vision for 2 weeks. Looking at the Humphrey visual fields, you can see an enlarged blind spot, both eyes. The right eye has a early superior nasal step as well. Fundus photographs show bilateral disc edema. In a pregnant woman, there's several things to consider on the differential. You consider a CVST in a hypercoagulable state, preeclampsia, eclampsia, hypertensive emergency, possible brain mass. For this patient specifically, the MRI is normal outside of mild posterior flattening of the globes and a LP with a slightly elevated opening pressure. So this presentation is most concerning for IAH. And looking at medical management of IAH in pregnancy, it's important to note that actually pregnant women are not at an increased risk of IAH compared to non-pregnant women. It's relatively same rate of occurrence. Ideally, if medications could be avoided, that would probably be the best option. So maybe weight management if possible. But if you do need to prescribe Diamox, it's typically avoided in the first trimester based on it's like critical stages of embryogenesis. But there was a study done in 2013 that looked at 158 pregnant women. 50 of those were pregnant in their first trimester taking Diamox, and there was no increased risk of spontaneous abortion or miscarriage compared to the general risk. And then as far as topiramate, I think it's generally avoided because it can lead to major congenital malformations, which has been studied in a lot of pregnant women with epilepsy. Moving on to another case, we have a 20-year-old woman with acute loss of vision, severe eye pain, involved in a motor vehicle accident. I know we've seen a few of these on call, unfortunately, but the pictures here, you see 360 hemorrhagic chemosis, possible open globe, and then combined with a CT scan of this very deformed right globe. It's definitely concerning for an open globe that needs to go to the OR. So looking at medications that we use in our open globe management, pred acetate has a grading of C. There haven't been any studies done in pregnant women, and there have been studies done in mice that show a teratogenic effect. That's potentially 1 to 10 times the human dose. And then for lactation, there's not really enough data to support whether topical drops are getting absorbed systemically to a significant degree, but systemic steroids are found in breast milk and can suppress growth. Subconj dex, no studies in pregnant women, does have a grading of C, could probably use it if the benefit outweighs the risk. Vigamox we talked about, Vanc, Ceftaz, and Tobra, same thing, not really any controlled studies, could probably use it if needed. Systemic fluoroquinolones, I know we typically do IV Levaquin for patients, but this is generally contraindicated in the first trimester. Some alternatives could be Augmentin or Unison, but the only thing it wouldn't cover is Pseudomonas and some atypical microbials. You could also try cefuroxime, cefazolin, or ampicillin, and then dilating drops just haven't been studied either. Last case, we have a 28-year-old woman pregnant at 34 weeks, history of pathologic myopia, presenting with sudden vision loss. Looking at the fundus photo, you can see a tilted optic nerve, peripapillary atrophy, and then within the macula, there's kind of this ovalish-shaped hyperpigmented area, reddish, in conjunction with the MAC-OCT, a very obviously labeled CNVM with subretinal fluid. Concerning for a CNV in myopia, and looking at the mainstay treatment, anti-VEGF therapy during pregnancy. This one was kind of interesting. VEGF is very important during pregnancy. It helps with vasculogenesis, neoangiogenesis, and maintaining the fetal and placental vasculature. The FDA recommendations specifically for Eylea in pregnant women, there haven't been any well-controlled studies that have been performed, but in rabbits, it has shown embryo-fetal malformations. But at the lowest dose that was used in the rabbit studies, that lowest dose was 6 times higher than a single injection of Eylea. So, you take that with a grain of salt, I guess. And then it's generally not recommended for women who are lactating because of potential excretion in milk. There was one study I came across that was published in Eye in 2023, looking at VEGF treatments in pregnant women and breastfeeding women. It was a case series and a systematic review. Overall, it looked at 42 pregnancies where they used different types of anti-VEGF treatment for different causes, and the general consensus was they couldn't really find a general consensus because there were too many confounding risk factors for patients who did end up having stillbirths, miscarriages. They were ultimately already high-risk pregnancies, so they couldn't exactly say it was the anti-VEGF medication that caused any problem. But one thing that I did read in this study is that they did recommend pregnancy testing for women getting anti-VEGF treatment who are of childbearing age or considering getting pregnant. So talking about all of that, it's how worried should we be when we give an eye drop that it's going to have systemic effects? So looking at systemic absorption of these eye medications. It's influenced by several factors: the drug's formulation, presence of preservatives, and patient tear films dynamics. And then during pregnancy, physiological changes also increase blood volume, alter protein binding, and can have enhanced renal clearance, which can affect the pharmacokinetics of a drug even more. A standard eye drop has a volume of about 50 microliters, and only 10% of that is maintained in the conj fornix. So you have an immediate loss of 80% of the eye drop volume, which is why a lot of these eye medications tend to be more potent. And then as far as absorption, there are really three main avenues. There's the conj, sclera, and the lacrimal system. Studies have looked at how much is absorbed in which areas, and it's estimated that maybe 1 to 10% is absorbed through the ocular tissues, and up to 74% is absorbed through the nasal mucosa, which has direct access to the bloodstream and heart and does not go through any kind of first pass metabolism in the liver. So minimizing systemic side effects if we are prescribing these medications for this population. Obviously, we can teach our patients about punctal occlusion anytime they're using an eye drop. Maybe even consider punctal plugs if a patient's going to be on a therapy for several months. Could lower the effective concentration, maybe do a compounded medication, wiping the excess drop from the surface, or using a topical treatment that has a higher viscosity, like a gel or ointment, so less is likely to go through the nasal mucosa. So key takeaways, having looked at all of this, there really are just not a lot of studies done for pregnant women and lactating women. And the guidelines should be considered when prescribing these medications. Should you need to use a category C medication, which a lot of the eye drops we talked about are category C, it's worth having that risk-benefit discussion with the patient, and you can directly access kind of what's been studied if you go onto open FDA.gov and look at those labels. The table there is the preferred ophthalmic medications for pregnancy, and that's adapted from Iowa. But hopefully if you scan the QR code, a paper should pop up that has like a very, very detailed table of 30 plus most common ocular treatments and what's safe to use and why medications are not safe to use. So I really like that table. I think it was a really helpful reference. Anyways, those are pictures of me bungee jumping. Thanks so much for your time. I'm happy to take questions, and also would love to hear any like clinical pearls that you might have in working with this population.